Hey everybody, it's Sean Gibbons from the Communications Network. If you don't recognize me, I know I got my specs on and I got my baseball hat on because I'm playing the Beatles very, very loudly. So I have to turn this down. This is George Went to India, Norwegian Wood, when the Beatles started to get a little bit more interesting. Dr. Wenzel requested the Beatles and Norwegian Wood, so I'm playing that for you just now. As y'all are entering the room, I'm just going to yak at you for a quick minute, make sure we make space for everybody. Thank you for being with us. My expectation is you're here because you are expecting us to have a conversation with Dr. Richard Wenzel, the epidemiologist and infectious disease doctor. The fifth time that he's joining us to share the latest on what we've learned about COVID-19, the novel coronavirus. So we'll be doing that in just a quick minute. But before we do that, because we've all been isolated and doing our very best over the last couple weeks, we've started to do this thing. Maybe you were with us before and you've done this, but a two-word check-in. So if you would, take your finger, whatever you have to manipulate your computer, go down to the bottom and you hover, you're going to see the chat button. And that's where we're all going to say hello to one another. So I'm going to go ahead and type in, hi, it's Sean. And if you would, go ahead and add in your name, organization, where you're coming in from, and then two words. Describe how you're feeling. For me, it's it's Beatles and headache. I guess they have a migraine right now, but let me know how you're doing. Hey, Dick, it's Betsy, your sister. How you doing, Betsy? Anxiety-ridden Tom. Okay. Jay, how you doing in San Diego? Grateful but tired. Yeah. It is just amazing, and maybe Dr. Wenzel can talk a little bit about the mental toll of these things and what we can all do to kind of keep ourselves mentally safe and feeling better. Colby, how are you? Full plate. Yeah. Donna, how you doing? Feeling powerless. Well, Donna, I'm glad you're here. I know I've had that feeling multiple times over the last couple of weeks, and it's tough because we really, in some ways, we still don't have a lot of agency right now, right? But we're all together, and we'll make a go of it for this next hour, maybe getting a little bit more information, make you feel a little bit better. Susan, how are you? Trishna, resilient and resourceful. That's a good way to be. Sean, my friend, how are you? Losing my mind, but hanging in. Yeah, all right. We're going to keep the Beatles going, gang, just for a minute, but I'm going to turn them down a little bit. What else we got here? Kanetta, how are you? You're enjoying the view? Lisa in Seattle, homeschooling and working. Oh, yeah, that's my reality. Jennifer is with us. Lori, how are you? Others, keep typing in. Say hello. You should know that our colleague Gab Sarah Ferris is going to be taking some notes on Twitter, as she always does. If you want to follow along on Twitter or see the notes afterwards, you can find those at the hashtag ComNetLive. That's ComNetLive. Deanna, how are you up in Pittsburgh? I was just talking to your colleague Doug. Rhonda in LA, how are you? I'm assuming it's a sunny day where you are. Again, if you're just joining us, gang, go ahead and not only tell us who you are and where you're coming in from, but give us two words. How you feeling? How you doing? Quick two-word check-in. While we're doing that, Yabby's taking notes on Twitter, as I just mentioned. Our colleague Carrie Klein, as she always does, is making notes. She will post those in a Google Doc. We will put those along with a recording of this session on comnetwork.org, on YouTube, and Dr. Wenzel's been taking the privilege of taking these and putting them up on his website as well. Mark, how are you? Still healthy? That's a good place to be. And Suzanne, you are so welcome. I'm glad that they're helpful. Like you, I think it's just nice to be able to sit down with a doctor and ask, what's going on? Dr. Fauci, I won't make any comments here, but he seems to be sidelined a little bit. So having a chance to talk to a real physician who's done this for, I won't date him, but longer than many of us have been around, is incredibly helpful. And it's also just true that, as Dr. Wenzel keeps saying, we're learning every day. What we know now today is different than what maybe he was telling us even 2 weeks ago. It's evolving, this body of knowledge that we're gathering. So with that, Tristan Mahabir, who's running the slides, I'm just going to give you a couple quick pieces of housekeeping. First is the Jones Award. You know what this is. We give out an award now every year. We have for the last 2 years. This will be our third year. We try to recognize an individual or institution that has changed the world using communications for good. That's the Truth Initiative was our initial winner. Desmond Meade last year. We run the Florida Rights Restoration Commission. We are is that right? I have the name right. In any event, we are looking for a winner for this year. The deadline is Friday to nominate the judges. We've got a number of tremendous judges joining us to help us sort out who the winner should be, but that winner will be recognized in short order. And we hope that over time, by recognizing folks or institutions in this way, we will build an archive of evidence that communications has transformative power. And so help us out by putting in a nomination. Try to nominate. Link said the survey was closed. Kanetta, it's not. If you go to jonesaward.org, and maybe Carrie can put that link in there, jonesaward.org. We had a bad link on the email, and I'm sorry, but you will find it in the link that Carrie just put in. Mr. T, if you'll take it forward. Com Network Local, this is the other thing I should tell you about. You probably know this, but in 17 cities around the country, we have folks gathering. Right now, they're gathering virtually, kind of like we are. But the idea is that if you live in Chicago or Detroit or Miami, you share a culture, you share some of the challenges and obstacles with other people working at foundations and nonprofits. And we've been bringing you together now for goodness, almost 5 years, I think, within these local groups. But right now, we're gathering virtually. And so I would encourage you to check them out. Com Network Chicago is gathering, I believe, later today or tomorrow. But go ahead if you go on, Carrie's tossing in the link for the Com Network local group so you can see where we're located. And there are literally 17 cities around the country. So if you're in Austin or Atlanta, Portland, LA, San Francisco, I don't want to leave anybody out, but suffice to say, there's a lot of places gathering. Please, by all means, it's free. You're welcome. We'd love to have you avail yourself of that. Mr. T, take it forward. Triage kit, I'm not even going to do this. So if you go on comnetwork.org, you will see that we have built a communications kit to help you try to figure out some of the very, very basics to communicate information in this moment. We based it on the CDC's crisis communications kit, which is 450 pages long. Ours is distilled down and really focused on foundations and nonprofits. Alongside that, there's a spreadsheet with examples of work that others have done that you are welcome to borrow from. All right, Mr. T, if you'll take it forward, and there'll be a link to that in just a minute. And then finally, Circles, brand new program launching soon for us. Idea is pretty simple. These are peer communities. We're going to gather you either by the issues that you and your organization work on, right? Whether that's social justice or public health or ocean conservation, or the role you play in your organization. Maybe you run a department, or maybe you lead digital strategy. In any event, that is coming and very, very soon. So keep your eyes out for that. And I think that's it for my kind of teases at the top. Mr. T, if you'll take it forward. I am right. Okay, so that's all I've got for you. It's now my pleasure to welcome Dr. Richard Blendzell back. He has been kind enough to join us once again, safely at home down in Richmond. And his sister Betsy's on with us. Everybody be nice. We will take questions in a little while, but first he's going to tell us what we've learned, what we are learning, and what we might expect in the coming weeks. Sir, let's take it away, and I'll turn off the Beatles now. Sorry about that, gang.
Yeah, thanks very much, Sean. And I want to thank everyone who's taken time to chart their way into this webinar. I show this slide primarily to say that my email's at the bottom. If something happens and you have a burning question, I'll do my best to send you a response. And also because I'll mention some drugs, but I have no equity in any drug company or any product company at all. So I have no conflict of interest. Okay, could I have the first slide then? So this is a picture, if you will, a representation of Dante Alighieri, perhaps Italy's most famous poet, who lived in the 13th and 14th century, died just before the pandemic of his era really took off. And that is, of course, the plague of the Renaissance. And what he says, my course is set for an uncharted sea. And I put that on there because there's so many unknowns still about coronavirus, COVID-19. And I think as we learn a lot about the virus, I'll point out the things we don't know, of course, that are still remaining. So could I have the next slide, please? So first, just to, again, remind you of the international trend lines. These are confirmed cases of COVID-19 for selected countries. And on the y-axis, you can see the numbers that are in log form going from 100 all the way up to 1 million. And again, you see the number of cases since the day of the 100th case for each country to level the playing field. And as you see, over 1 million now, the United States way up top. And we got a little bit of late start, and we're hopefully just beginning to reach the plateau, but a lot of uncertainties. The countries below us, if you can see, Spain, Italy, France from Europe, are all trending towards a flat line, and hopefully that will continue. If you look at the blue line with China, they peaked very early in terms of having a flat line, and so they really introduced strong controls and are doing well. And I always want to point out at the bottom, Australia, and I would add New Zealand, both islands that institute very strict control measures early with social distancing, a lot of uses of testing, and actually limited, if not stopped all incoming flights to their island. So they've really done well, and it's an example. They're actually talking about eliminating the virus, not just controlling it. Next slide. So there's a lot of discussion about the Swedish experiment, if you will. And so this slide shows the new confirmed cases, average 7-day average going on here. This is day since the 10th, 10 average cases first appeared. And if you look at the United States at the top, on the top left, we're about 20,000 cases per day on average. And Sweden, lower than ours, but still about 500 cases per day. And then if you look to underneath to where Norway is, and I have as an example the United States, Norway is down around 50. So Sweden at 500 has 10 times the average cases than their neighbor, Norway, that has a much more strict social distancing. And I'll come back to that. And then if you look at the bottom right, I put Austria in there because it's the same size country as Sweden. It's also down around 50, even though, and again, not a neighbor, but same size. And Finland, again, another Scandinavian in the upper right, again, hovering about 100. So fivefold lower than Sweden. So if you just look at the average number, you'd say, so far, we don't have a lot of evidence that the Swedish experiment is doing very well. Next slide. Take a little closer results, and I would say these are early, to be fair to Sweden, and I would call this a Swedish experiment. That does carry risk. Now, it's true in Sweden, most travel and mass gatherings are prohibited, but some of the pictures that you've seen of Sweden, it looks pretty crowded, some of the parks and bars. Some schools are closed, but restaurants and bars are open. And in some of the reports, 25% of the people have antibodies, recognizing, of course, the problem with overcalling the proportion of positives. If you want to compare them to the United States, you know, there are some differences. They appear to be a healthier population than we are. A fewer lower proportion that have obesity, diabetes, for example, hypertension. Their death rates in this experiment in elderly patients are high. And now to put some equalizers in, if you look at the death rates per million, Sweden is higher than the United States. There are 319 deaths per million. We're 242. But if you look at the neighbors of Sweden, Denmark, 91, Finland, 48, Norway next door, 40, Iceland, 29. So again, early results are a little bit of concern because the risk looks like it's still going on. Their epidemiologists may argue, well, we have to wait and see what happens in another 6 months. But so far, the early results raise some concerns. Next slide. Now, the United States, of course, if you look at the total cases on the left and total deaths on the right, we're over 1 million cases, and we just passed about 83,000 deaths. So our rates are still climbing somewhat, and we'll get a closer look at that. Next slide. Now, this is an interesting slide for me that was published in the Washington Times. And if you look at the various parts of the country, whether it's on the left, states from the West Coast, and underneath that, other Western states, I want you to look at the size of the band that's yellow, meaning the proportion that came from the West Coast, particularly Washington State, and then went into the other states, or the proportion, if you will, of the red or pinkish bars, and those represent the proportion that actually came from New York. And again, on the West Coast, you see, well, in Washington, 53% came from Washington State, California, only 32, and Oregon 30, and they got still even way out there. Most of the cases, as is virtually all of Alaska, from New York. Other Western states, as you can see, you can see the same thing, a huge impact of red, meaning the cases came from New York. Now, just to remind you, from the West Coast, such as Washington State, those cases came from China. New York, the majority of cases came in from Europe. And whether you're looking at Midwestern, Southern, or Northeastern states, you can see the enormous contribution of the spread of particular viruses that can be actually fingerprinted to have come from New York State and New York City to those states. Next slide. So how are we doing? Well, if you look at the number of daily cases, and if you look at the bottom curve, lighter blue, New York, Detroit, New Orleans, you can see that, well, in the early weeks of April, we began to peak and now see a decline. However, the problem is that the rest of the United States is climbing in the number of new cases per day. And some hotspots give us some encouragement. But remember, all those cases from New York migrating to the Midwest and West from New York are causing the rates to rise in the rest of the country. Next slide. So remind you just how this virus is being spread. And on the y-axis, the number of new infections caused per day, they're color-coded here, as you can see, and you can also tell the proportion. So if you look at pre-symptomatic, the light blue top, looks like 45% of infections happen from carriers before they develop symptoms. So they had no symptoms, but probably in the next 3 or 4 days, they will develop symptoms and they can transmit. And they're transmitting a huge proportion of the infections. Symptomatic people, 40% of infections transmitted from this group of people. And they might have very minor symptoms, or they've convinced themselves they're not really sick, but they are transmitting a large proportion. The environment accounts for probably only 10% of infections, where somebody touches the environment, the virus is there, someone else touches it, then touches their face, their eyes, their nose, their mouth. Perhaps 10. And totally asymptomatic, perhaps that's somewhat good news. Only about 5% of the infections, people who never get symptoms. So it's the pre-symptomatic and the symptomatic people, 85% of transmissions occur with them. Next slide. Now a little bit about herd immunity. And what I have is 3 scenarios. And what we're trying to do is reduce the number of susceptibles and protect the rest of the community. And as a starter that isn't on here, we think that herd immunity in our country for this virus would be about 70%, would require protection either from natural infection or from a vaccine, hopefully. So if you see everything in red means that the dot at the bottom in black spread to all 3 at the top and all 3 at the bottom. And I have it R sub 0 or R naught it's called. It's the case reproduction number of secondary infections among susceptibles for each primary. Well, epidemiologists now are reminding us there's another denominator, and you shouldn't call them all R naught. And R sub 1 is what they call the effective reproduction number. Doesn't assume a susceptible population at all. Just of all the people, how many does one case transmit? And again, if you look at the 2 scenarios in the middle, you see the dot and only 1 red line to 1 patient at the top and 1 for 1 at the bottom example. So you would say R sub 1 is 1. Some people are calling that R naught, but the people would argue about that. Then if you look on the right, you can see that of the 2 examples where you might have a maximum of 6 transmission, you're only getting 1. So R sub 1 is less than 1. So an epidemic will continue as long as the transmissions are greater than 1, and we're beginning to control it when R sub 1 is less than 1. So remember the effective reproduction number, no assumption of a susceptible population. Next slide. So are we rushing to open up societies? So I've told you we have many susceptibles. Most people would say maybe only 5% of the country has been infected. Others would say 10. There might be a few pockets where the New York group has said, well, maybe we're as high as 2025. That's still 75% susceptible, and maybe it's really closer to 90 or more. We still have insufficient tests available to be able to track success or failure. Most states opening up now have rising infection rates. This is why I showed you the contrasting slide, showing the rates rising for those areas outside of New York and a few hotspots. The CDC models, some of them show many thousands of new cases by the 1st of June. And the University of Washington models 134,000 deaths by early August. And then another question that is really important for store owners. Do people feel safe in social conditions today? Because even if you open them up, if people don't feel safe, that may not go. But I'm raising all these issues because I have great concern that we're rushing to open up society when we haven't solved some of the issues listed on this slide. Next slide. So if you look at the first million cases reported and ask ourselves, you know, if the cases increase, proportion of the population increases, what's happening to our deaths? So if you remember that we hit the first million cases, which by the way is less than 1% of the population, as you can see, we had about 60,000 deaths at the same time that we had a million cases. And today we have about 1.4 million cases, still hovering less than 1% of our population, but now we have 83,000 deaths. So the questions I would leave you with to think about is, what if we had 10 times as many infections? That would only be 3% of the population infected at 10 million. How many deaths would there be? Here's our baseline, 83,000. What if we go to 100 million and 33% of the population, a third of us, again, how many deaths? And to get herd immunity, we need about 200 million of our people infected. And we're looking at the Swedish experiment to get a percent of the population for herd immunity, about 67%. How many deaths on the right-hand side? They're not going to end. And the big unknown is how fast and how many. So if we rush to open up the society, the risk could be formidable for our population and to the healthcare sector. So I think we have to just keep these uncertainties in mind. Next slide. Now, one of the things that I'm surprised that CDC hasn't really clamored about the public health challenges ahead. If you look at the fall of 2020 and 2021, even with and beyond COVID. And I think they need to really sound urgency. And I think they've been behind in doing that. We're going to have continued COVID-19 cases. It's not going to go away this summer. The only questions are, will it stay flat in the fall, or as many have been concerned, surge to even higher numbers, as many more introductions might come from the winter south of the equator, people visiting the United States in our summer. We're going to have continued COVID. What the CDC hasn't said is we're going to have the added influenza burden on top of our COVID, no matter what that line looks like. And that's going to be a large or modest size burden, but it's still one more thing to worry about. And I've said this before, but if you ever had a year when you want to get the influenza vaccine for you, your coworkers, your staff, for your family, this is the year. We know it's not a perfect vaccine, but this is the year. And then we know that we've had more natural disasters in the last 5 years. So CDC is going to have to handle, to some extent, as well as FEMA, hurricanes, the risk of a forest fire, the risk of an earthquake, on top of COVID and flu. And another thing that just come out in the last couple of days, there's been a 40 to 50% decline in the receipt of childhood vaccines. So outbreaks are possible. So you can imagine a CDC trying to deal with COVID, looking at the added bump from annual influenza burden, possible natural disasters, and then maybe outbreaks of measles or mumps on top of everything else because of the decline in receipt of childhood vaccine. Hopefully that'll turn around. But we really need to build a robust public health preparedness for the fall of 2020 and the winter of 2021. And I think CDC needs to really stand up and hit the bell on this one. Next slide. Well, we have some drugs to treat COVID-19, and most of them are in trials. And the only one that's come out of trial is remdesivir, which is a modest improvement, but it does shorten the recovery time from 15 to 11 days. And as a secondary endpoint, had a non-significant reduction in mortality. So at least we can say we have proof of concept that an antiviral actually slowed things down and helped recovery. There are a number of drugs that dampen the aberrant immune response, which is the cause of the so-called cytokine storm late in the course of severe COVID-19. And just to know that they have strange names for those of you who don't follow this, but interleukin-1 receptor blocker, a small retrospective study showed some clinical improvement and just was published recently. And what I would say about all retrospective studies, they need confirmation in other studies, if not in a prospective trial, which is the ideal. Something called an IL-6 receptor blocker. There are several candidates that are in clinical trials right now. And then more recently, small molecule inhibitor of calcium channels, which are also, these channels are on the immune cells, and if stimulated, can lead to the cytokine storm. So what people are doing out there is saying, look, we're going to try to dampen the immune response to save the response and maybe the lives of people out there. And the good news is there are a lot of horses in this race. With hydroxychloroquine, we have to say mounting evidence, no evidence of utility. Now, we also are using antibodies for both therapy and possibly in the future prevention. So convalescent serum is one form of, and as intravenous immunoglobulin. So one of the things about intravenous immunoglobulin or even antibodies, the half-life is about 3 or 4 weeks. So you would have to redose people if they were sick that long. But some people are talking about preventive in the high-risk people. So if you had an effective immunoglobulin to give, for example, everybody in nursing homes, you might have to give them an injection every 2 months in order to keep this going. Hopefully we'll have that, because that would be a medical bridge to the vaccine. So there are things out there, a lot of uncertainties, a lot of trials going on, and I think that's been really helpful. Next slide. Now, the typical timeline here would be, if we're in 2020, we really wouldn't have a vaccine for 16 years. Scary when you think about it, and we don't have that kind of time. But academic research often takes a couple of years. What's happening today, nobody's doing any academic research. We're moving right into the trial with preclinical in animals and sometimes bypassing very quickly, if not, to phase 1 trials, which mean maybe 10 or 20 people to look at safety. Phase 2, now you're up to 100 people or several hundred, and you're looking for safety, any signals of harm, but also, does this lead to an immune response? And now we're coupling phase 1 and 2 together. It's going to save years. Phase 3 is a large trial, hopefully in the thousands, to see again any small signal for danger, and do these people immune, and will it protect them, which would be ideal. Building factories, well, that's already been shortcutted by many people. Manufacturing can be shortcutted, which I'll show you in a minute. And then approval is going to be a race through. And then finally, we have the distribution. So we possibly can take these 16 years, knock them down to anywhere from 1, maybe a little less, to 2 years. And I'll show you that next. Next slide. So the vaccine candidates that we typically use, when somebody asks a question, for example, how long will it take to get a vaccine? The quick answer is depend what kind of a vaccine we have. And all kinds of vaccines are being tested. So killed whole virus, just as with influenza. You can take the virus, subject it to something that kills it, inject it into the body. It won't cause flu, but the immune system recognizes a lot of parts of the virus and will build an immune response. Some people have argued, and we have this for flu vaccine, that live attenuated virus is good. Attenuated is a term that means we've taken the sting out of it. It's not going to hurt you, won't cause flu. And again, it's a modified vaccine, and we make immune response to it. And if you look at the right-hand side, all the particles, if you will, the docking sites for the coronavirus, some people are working on just a vaccine that would deal with the spike itself to stop the docking that would start the infection in the body. Again, that's another type. Most of these will probably take 1 to 2 years to really get there. We might be able to get down to a year, but it's a while. There are so-called benign viral vectors with genes coding for critical viral proteins. So what happens in this is you take a virus, it's harmless, you hope, and we test it, and you actually get a hold of the genome, the genes of that virus, and insert a gene that makes one or more critical viral proteins for the COVID virus. So it's injected in us. We have no side effects from the virus, and our body and the virus makes the gene, the special gene that codes for the viral protein, and we make an immune response to that viral protein that exposes itself to our immune system. You might think of this as kind of a Trojan horse vaccine because the gene is actually being carried by a benign viral vector. Probably the most exciting and the most rapid turnaround is with the so-called messenger RNA vaccine, mRNA vaccine. These could maybe, if they work, be available as early as late fall or mid-fall even. And there are a lot of reasons for that. Remember from your biology class that unusual protein production, the nucleus houses the blueprints. That is all the genes that give us instruction to make our own protein. And then a step is formed in which a single strand of the instructions is copied in the nucleus called messenger RNA. And that messenger RNA is ushered into the cytoplasm, which is where the factories are in the cell to make the protein. So the mRNA vaccines contain specific genes coding for critical viral proteins. And they doesn't involve doing anything with the nucleus or not injecting live virus. There's no danger in the lab of a live virus, and there's no danger that that virus will integrate with our own genome and maybe cause some problems for us. It's an adaptable process. In other words, if we're going along in this platform, which is already available from SARS and MERS studies, if the virus were to mutate, the scientists could actually modify the mRNA and take care of that. And you can have scaling up very rapidly. So when people talk about the mRNA vaccines, they're talking about a system that has a platform already and rapidly could be moved through the process with a vaccine, perhaps as early as mid, maybe even late fall. Next slide. So today I really want to again reminding us of all the challenge that is restoring health in the economy. We need to do both. Again, emphasize over and over, this is not a binary issue. We need to restore our health and the economy. What's happened through a lot of administration throughout the country is that the federal government is focused on the economy and the states now are left to focus on health. And unfortunately, there's been no national program to integrate both and have a single plan. So what I would suggest is at the bottom, we need a national plan to promote both health and the economy. And I'm suggesting an alliance of some type between CDC and Congress for a national plan, a national message. And we need a national plan for health and a national plan for financial stimulus for small businesses who are suffering the most. Again, emphasize national and a single plan, perhaps with minor variations for small areas of the state for both health and for the economy. Next slide. And even within the health part, the COVID-19, I want to emphasize a two-pronged approach, because we hear arguments out there. Well, we shouldn't focus on the general population, just the high-risk areas like nursing homes. But in fact, we need both. And there's nothing wrong with a two-pronged approach simultaneously. So for the general population on the left, maintain social distancing because it works. Masks work. The face shields prevent you from touching your face. Isolation of all cases and intense contact tracing, quarantine the contacts. And for all of this, we need a massive increase in the number of available testing. At the same time, we recognize that nursing homes house 20% to 80% in different states. But overall, a third of all cases in the United States are nursing home patients, as low as 50% in Pennsylvania. I've seen as low as 20%, and Wyoming, I think, had as high as 80%. Prisons, a breeding place, we need to figure out a way to manage that. Same with homeless shelters, meatpacking facilities. In some states in the Midwest, a large proportion of the cases are in those counties where they have meatpacking facilities. I'd really like to, again, emphasize it's not a dichotomy. We need both. Next slide. So a third approach, we have the economy we need to fix, we need health, and a third approach came out as a suggestion a few days ago in the journal Science by a couple of scientists. Scientific innovation to supplement the efforts to restore health and the economy. So what the authors argue is that COVID-19 has reduced the gross domestic product by 30%. The NIH budget is $3 billion. That equates to a gross domestic product loss of 4 hours, to give you an idea. The daily loss of the gross domestic product, 6 times that, are 18 billion. The US government is spending 2.8 trillion to compensate for the economic shutdown. Now, what happens if we open the door and really sponsor a great deal of increased research? We all know research carries a risk. And basic science, the odds might be about 1 in 1,000, 0.1% chance of a key advance with any one protocol. However, if you take 10,000 new projects, probably fund them at a $1 million to $3 million each, there's a 97% probability of 5 key successes. I think this is a strong argument that we ought to build, not cut back on our research portfolio. And this could come under a new name, might be the new COVID-19 Defense Research Fund. But I think this is something we should really keep in mind. Next slide. So periodically, I'm asked, and a lot of people are asked, and people are wrestling with us all around the country. When can we open up colleges and universities? And what are the challenges and risks? And as you know, California system, 480,000 students decided they weren't going to open in the fall. Montreal, McGill University, I just heard today, part of Harvard's program is not going to open in the fall for in-person teaching. So if I were asked by a president of a university, how can I really open up my school? Because 70% of colleges say they're going to open up, 70%. So my question to the president of the university would be these 5. What's the goal of your new program? I mean, specific goal of your new program to open up. And if you hear a vague answer, well, I'm trying to find a balance between A and B, that's not a goal. That's a value system. What is the specific goal? If you are here and you want to get there, what does the there look like? Two, can you define the long-term strategies and short-term tactics of the program to get you to your goal, to the there? Specific. Third question is tough. People don't like to hear it. How much risk can you tolerate? That's a benign way of saying, what's your bar? How many of your students enrolled will get infected before you say enough? How many students at your institution, on your campus, will be admitted to the hospital or admitted to an ICU or intubated or die before you say enough? I think you have to have that on the plan. Fourth, how will you measure success or failure? This to me implies routine, systematic, repeated looking at the student body and all the teachers and staff for virus by screening them weekly or every 2 weeks. Now, when you get back and you say, okay, you want to open up, you're going to do a lot of, still home learning. What's the education and learning experience? Can you articulate what does it mean to be in a university? Remember that the word academy comes from the word academia, Greek word, which was the park where Plato taught his students in small groups, challenged them, got to know them, disturbed their biases as they came in, made them grow. Can you really have that kind of academic education when you're doing strange things to your program? Next slide. So I close with this quote because I think in order to control this pandemic, we're going to need everyone engaged. And to do that, I think you need empathy. We all have to appreciate the value of social distancing. We all have to evaluate our program to support local businesses. And just one example, we need to maintain standard vaccination. That's a contribution, all of us. And Barbara Kingsolver, the author, said this: empathy is the capacity to understand that someone else's pain is as meaningful as your own. Let me stop here. Thank you for listening, and I would look forward to trying to answer any questions.
Thank you very much, Dr. Wenzel. We have a number of questions. One came in as you were talking, and it's probably just worth to sort of level set for everybody. As you were sharing some of this data with us, the question was, what are some of the sources that you were using to gather this information, whether that's looking at the outcomes we're seeing in Sweden or some of the drug trials that we've seen and the therapies that we're noticing?
Yeah, it's a great question. So the drug trials, a lot of those are in the published literature. The remdesivir study obviously came out from Tony Fauci before we had a chance to really see it as a peer review. But the hydroxychloroquine study is showing that it really doesn't do well is in the peer-reviewed literature. There are a number of archives that are papers that are undergoing review that aren't peer-reviewed that are available. You have to be critical of those and say, I haven't undergone peer review, but do that yourself. A lot of the data come from CDC and news outlets. Washington Post, the New York Times often has graphics and their own people. And for the most part, I think they're consistent with what states have also reported as well. So I think the questioner is asking a very good question and probably hinting at, how reliable are some of the data, and I appreciate that.
And that's just a challenge that we're facing because we're moving so swiftly.
Yes.
I'm going to take the privilege of the first question, and I'm going to be very, very blunt because you've been very forthright with us. Without sugarcoating it, how are we doing on testing? Where do we need to be? And maybe you can do that in terms of just what the numbers need to be for us to feel, for you to feel comfortable to say we should be moving in a good direction.
Yeah, we're really way behind. If you were to grade it, you'd probably give us at least a D. But not much better. We're way behind. And what we really need particularly is the test for the virus, particularly, because if we're going to follow all our employees in a business, so and all the students at a campus, We have to know who has the virus, recognizing the shortcomings, which I've described before. A positive test will overcall a positive. So if you have a company of 100 people, and if you said, oh, I have 10 positives suddenly, well, I'm going to tell you that somewhere between 2 and 5 are false positives. That's a real disruption for you. But public health response would be, we don't care. We'll treat them all the same. I know some of them aren't there, but I'm going to go and ask them to isolate themselves for 2 weeks. I'll track their contacts, ask them to quarantine for 2 weeks. Nobody gets hurt. Good primary care, good care, and public health management. The problem comes with antibodies, because we still have the same problem with antibodies, and that is they're false positives. But if you say, well, what do we do with that? I think it's primarily an epidemiological tool to look at trends over time. So if we had 5% of our population tested every week or two, and we saw the trends change, I would believe the general trends. If you said, I own a business and I have 10 people that have positive for antibodies, can I let them back into crowded rooms or crowded homes? I would say no, because you have enough false negatives, in this case, a false positive for antibodies, that you're going to have some people who really aren't immune, and you're going to expose them. So we really need to focus on the tests for the virus, including the antigen test, which has a lot of shortcomings, and the antibody should be for the public health to look at trends. We're doing very poorly so far. I think everybody, I listened to the Senate hearing the other day with Tony Fauci, and both sides of the aisle that were questioning him said, we need more tests. I agree.
Okay, we have a number of questions coming in. As I start to pull these up, and gang, you can both put your questions in the Q&A box, which is next to the chat box, or you can vote for questions. So let's make sure we get to the ones you want the most. Dr. Wenzel, as we started, you heard people checking in, a lot of folks feeling tired, heard the word powerless, a lot of anxiety. I'll testify, we have 2 little ones, as you know, here at home, both this week waking up with nightmares related to COVID, scared that they were going to infect the family. The mental toll here is significant. Any recommendations or thoughts of how folks might mitigate that for themselves or for loved ones?
Well, being informed, I think, helps people a little bit. Because first of all, the denominator is very large, and the numerator, the number of cases of this frightening outcome that appears to be a sort of a sequel, if you will, 2 weeks after the infection with COVID. A very unusual syndrome that is inflammatory in nature and a vasculitis. And when people say that, what they mean is there's inflammation in the blood vessel itself. And the blood vessel itself is swollen and it's full of white cells. So when you have swollen blood vessels, you don't get as much blood. So if it goes to your lips or your conjunctiva, your eyes, you could get some, small hemorrhages, for example. If it goes to your heart, and a critical part of the heart isn't fed, and there may be more complications than that even, then you could have a weakened heart, and these young children presenting with congestive heart failure. So we're learning about the syndrome. We know it's very uncommon. I don't understand why we didn't hear more about this from China, and what does that mean yet. But I think being informed, particularly of the low rate, and know if your young one has severe abdominal pain, has a rash, has a conjunctiva that are very red or a mouth very red, this is the time to call immediately your pediatrician and take care of it. They don't care if you overcall. Don't worry about bothering them. You have one priority, and that's the health of your child. Don't hesitate.
And then for the adults who are also obviously managing, working from home, juggling lots of things, any suggestions on how folks might manage some of the stress or anxiety that they might be feeling?
It's really a tough question, because I think what we should do is periodically have a little bit of time to ourselves. Now, some people like jogging or walking fast. And I think any exercise, I've always thought, is really good. It's good for the heart, but it's also good for the head. So people who can do that. If you enjoy meditation, this is the time to do that. And whether you have 10 minutes or you have an hour, I really think that helps people. and I think contact with other people. So we're isolated, but we can call somebody that we care about, who we care about, and actually tell them that we have really been uncomfortable. We're anxious. We're feeling exhausted. We don't sleep well. All of that's true, and it's probably appropriate. There are some people that may or may not have underlying anxiety or depression. And if this begins to really weigh on them, you need counseling. Don't feel that you need to wait at all for that. And the counselors have reported recently in reports and the news articles that they're seeing a huge rise and even success with online counseling. Don't hesitate if you're actually on the end of that.
Okay, first question comes from our friend Sean up in the Northeast. He asks, how promising is what we're calling the Oxford vaccine? I've read about the possibility of millions of doses just this year, assuming that testing proves effective because manufacturing has already begun in anticipation of approval. So we talked about this a couple of weeks ago. Is there anything new to tell us about Oxford?
Yeah, I don't know about anything new, but I think to remind people what they've done is they have a platform that's really accessible to rapid production of the vaccine. They're combining their phases of vaccine, 1, 2, and sometimes getting started on phase 3, larger numbers. And the other thing they're do, which I really applaud, and I think hopefully they'll get compensated for if it doesn't work out, they're going into production way before they know that this is both a safe and effective vaccine, which means that we could have millions of doses the day that they find out, break the code and find out this is really safe and really effective. So they've saved months by doing that, taking a risk that if the vaccine isn't safe or it really doesn't work very well, that's all for naught. I think that's a marvelous response in 2020 to COVID-19.
Our friend Colby asks, many of our organizations are trying to build plans to reopen our offices or re-engage with the activities that may have been put on hold due to the pandemic. And we want to do this over the coming months. So for example, returning from the work from home regime to coming back into the office and resuming perhaps small in-person meetings. But there's so much mixed information out there from the federal, state, county guidelines, even your cities, and there's different science reports. It's just not easy to make good decisions. Now, Dr. Wenzel, if you were building a reopen plan for an organization that you were leading, you talked about this a little bit with the university, but more broadly, what factors or data or sources would you be looking to help guide your plan? So I'm going to appoint you for the next 10 minutes. You're in charge of the Ford Foundation, or you've just become the CEO of the World Wildlife Fund. Your folks are all working from home. They are anxious to get back to work. Lots of work has been interrupted. The government, Governor Cuomo has just reopened the state. What do you do?
Well, first, what you do is, let's start with what we know. Social distancing works. And the 6-foot distance is not perfect. It's reasonable. We know droplets can go beyond 6 feet to 10 feet or 15 feet sometime. But in general, social distancing. We also know that masks work. And I think we should continue social distancing and masks. Beyond that, I think to come back to a question I would ask all presidents of universities and all owners, if you will, of factories and industries. How are you going to know if you're a success or failure? You have to do testing. And again, I would do viral testing repeatedly on both the staff and the workers. Now downstream, what I'm thinking about is 2 areas. One is the workers who come back to your institution want to know you're doing everything to protect them. If you fail with not doing everything, they're not going to be comfortable coming back. The second thing I think is the leaders. This is a time for leadership to show empathy. And I think empathy is really important, to recognize that you're really sensing their anxieties, their concerns, their families' concerns that they come back. And you're going to feel, as I quoted before, their pain is as interesting and as important as your own. So I think we have to do all of those things. So it's testing, doing everything we know that works. We're going to measure periodically, hopefully weekly or every 2 weeks. And leaders have to show empathy. If they don't, they're going to have trouble. There
Okay.
may be more specific aspects of that some of your people would like me to answer.
And we will get to that. So, gang, if you have questions, stick them in there. We will get to them, as many as we possibly can. And Dr. Wenzel's been kind enough to share his email. So I'm sure if you don't overwhelm him, he'll be happy to answer questions specific to you. Deneen, and I hope I'm pronouncing that properly, forgive me if I'm not, asks, is there any scientific evidence that the virus is already mutating and potentially reducing the success rate of a vaccine or antibodies? And I guess I'll just
The
leave it.
virus, all RNA viruses mutate frequently. And so this one has to some extent, and that's how I was able to show you the fingerprint from New York to other states, including the Midwest and West, versus the fingerprint of the virus that came from China to Washington State and then moved to some other states. So the virus is mutating. There's no evidence yet that it's mutated to be either more communicable or more dangerous. Uh, it's hard to believe it'd be much more communicable, but it could become more airborne, for example, which would, in theory, be the worst thing could happen, perhaps. No evidence that that's happening at all. So yeah, you'll read about mutations, but so far, nothing that I've seen that any of the mutations are harmful or even making the virus more benign, which can also happen. So what's happening is these viruses mutate. There's a failure, a proofreading of the genes, if you will, and they get some changes. And the virus is kind of out there experimenting. How do I make a life? How do I hang in there for a long time? And so it's always going to mutate. We're fortunate so far that it's mutated, but no worse.
In my recollection, I hopefully this isn't a dangerous thing to ask, but my sister Becky, who you know, is a doc, and she had said her recollection was that SARS did not end up traveling far, both because it was very deadly, and so it didn't get a chance to travel, but also that it actually mutated out of being infectious to humans. Is that a possible path for us?
Yeah, it is a possible path. I mean, SARS had 8,000 cases, 800 deaths, so about 10% mortality, 10. But it didn't transmit very well, and it slowed down. And I think we probably gave ourselves a pat on the back, and we got lucky. So it wasn't just infection control. I think there was some luck, and maybe that could happen, but I don't think we can count on it.
Okay. A couple of questions here, more practical. Beaches are opening up in many, many states. Folks have some plans, maybe a vacation in June or July. Thoughts on that? Should you proceed, or is this the year to maybe think about a more local time off?
Well, it depends what kind of vacation you're going to do. I would be cautious about lining up a vacation where you're expected to interact with tens or hundreds of people. And a cruise would still come to my mind. I would not be the first one to get on a cruise in June. And so then we'd say, well, what would be the safest vaccine? Well, if you love camping and you're going to take your family camping, I think that would be terrific. And you're really not going to see other people. You still have your mask in case you're on some busy area sometime. You have to go to the grocery store, something like that. So in between, if you say, well, I'm going to go to the beach, it's only our family that'll be in the rented apartment or house. Again, there's still some risk because when you go outside, I think you can walk on the beach, which I really think is okay, so long as the beaches aren't, shoulder to shoulder with people. So if you can do that, have your mask available just in case you go to the store or the beaches become crowded, get off them. So in between, know what risk you're willing to tolerate. But I think there's some safe alternatives out there besides just staying at home, but you have to like the alternatives.
Our friend Tracy shares, I live in the epicenter in New York, and I just got certified to be a contact tracer. What do you know about New York's contact tracing program, and how many contact tracers will we need in order to be effective in New York and then throughout the country?
Well, I've heard numbers of 30,000 or more contact tracers. I have to apologize. I don't know what the specific program is for how many tracers in New York, but some people estimated for each case you might have as many as 7 or 10 or more contacts. That's still a lot of phone calls trying to get a hold of people. We don't have the luxury that China has of automatically having artificial intelligence and know exactly the pathways that every citizen went in the past 10 days or so. Our country probably wouldn't tolerate that intrusion. So we have to do it the hard way. Shoe leather epidemiology, that's called, where you go out and knock on doors or you do some phone calls. So I will try to look into that, but I don't know specifically the needs for New York, but I'm sure they are substantial.
Samantha asks, as mistrust of our government grows, or as mistrust of government grows, how can we allay community members' fear about contact tracing as a way to gather information about them, particularly for undocumented folks or other communities who may have a deep distrust of people asking them questions?
That's really a perfect question today, and it's not easy to answer because some people, I don't think it's all, but many people who mistrust the government um, are not impressed by facts or logic or science. And you have to use some other way to try to get them engaged at least. And when I've heard people talk about that, psychologists say the best thing is not to challenge their beliefs, tell them and use any epithets to describe their thinking, but in fact, begin to ask some questions. Well, what is it specifically that you feel uncomfortable about with the government? What parts actually work for you? And you begin to open up a door. I recognize that sometimes the doors don't open up at all. And some of the people who are um, anti-government, also anti-vaccine people and anti-climate change people who deny climate change, they often go together. And one of the sad things that I saw recently was a poll run by one of the major networks saying that even if a vaccine were available, 25% of the people in that survey said they would not take it. This is a big concern because, again, if you're banking on herd immunity, 70%, it cuts it pretty close if we really had 25% of people who aren't going to take the vaccine. So the question is really appropriate. It's very hard. And the best is try to engage in a non-confrontational conference. What are the pros and cons that really worry you day to day?
Our friend Kim asked a question. She said, Dr. Wenzel, during your last presentation, you thought that the number of deaths could be 100,000 by June 1st. So in just a little bit of time now. And do you think that number is still accurate? And have multipliers been consistent? And have the multipliers been consistent? So that replication rate that we were talking about, the R naught.
Yeah, it's good. Certainly, I think it's possible that in a little over a week that or so, or 2 weeks, we could get to 100,000. And by the way, just to put it in perspective, that's the number for the Asian flu in 57, Hong Kong flu in 68. Really big, horrible influenza outbreaks. And remember, that's the whole. We're still going through this process that isn't going to end magically in the fall either. So we're going to see cases through the summer. So I think 100,000 certainly possible there. What's the multiplier for deaths? We're doing better now. I think initially I thought that we were really way under, maybe not as high as some other people thought. Maybe we should multiply both cases and deaths by a factor of 5 to 10. In New York, they probably had 10,000 cases before they recognized that they had COVID there. Many of those patients died and they had strokes or heart attacks, probably related to COVID. They never got tested. Other people just died and never got tested. So I think we underestimate number of deaths today, but I don't know where that number is. So if we count 100,000 by June 1st, I wouldn't be surprised if it's really 120 or 30, but it's probably not 3 or 4 or 10 times that.
Okay. Karen, our friend, asks, is the opening plan that Dr. Wenzel shared for all sizes of organizations? So if you were going to reopen, and what she says, she's repeating back what she heard, which is regular testing, an evaluation plan, what's the actual strategy, how do we know if we're reaching our goals, adding masks, Is that applicable to every organization, or is that organizations over 50 people? So if you're a smaller shop, you're 10, you're 20, you're 30 people, do you still need to apply those kinds of protocols?
I would. I don't see any advantage if I were, the odds go up with more people. That's some probability that a tight quarters with 100 people more likely to have someone infected than tight quarters of 10, but it's not zero. And that's how I would apply that. Until we know more, until we're further into this, there's still some risk out there that isn't zero.
And I'm going to take the privilege of another question. Actually, Catherine has a question we'll get to. The president of Brown University has been very vocal about the need to reopen the university. I presume that's this fall. Do you think this is achievable with social distancing? You talked about this just a moment ago. What about the ventilation issues that we saw with a Chinese restaurant example where a whole bunch of folks got infected due to the airstream? I'm not sure I know that exact example, but thoughts about our friends at Brown University, or frankly, whether that's a university or even some of the primary school systems out there that are trying to consider what they might do come fall?
Yeah, there's a lot that we could do with social distancing, and certainly very little has been discussed about ventilation, which I think is important. Whether you're in a 777 that recycles some air again, or whether you're in a university or a restaurant, which has been shown that the air conditioner can push the flow of air in one direction. The biggest problem for me, which would face Brown University, and I give you good luck, is how do you manage the dorms? Remember the population we're talking about. Young, socially anxious people who love getting together. Young people who have a certain appropriate, at that age, disdain for authority. Young people who feel immortal. Young people who have hormones raging in the bloodstream, and you're going to tell them they're going to have to socially isolate themselves in a dorm, or when they go out to celebrate a weekend. I don't see an easy answer for that at all. And best you can say is you put in some kind of distancing and instruction to minimize the risk. But I would ask the president of Brown, go back to the 5 questions that I put on my slide. And I'd like to hear that, where your threshold is, particularly for pain, and what you're going to do. But I think it's going to be very tough. And I think we'll see in the next week even more universities say, we're not going to have in-person type of enrollment this year, or at least in the fall. They may come back in the winter. For those that go ahead, they have to know there's risk, and we can maybe have a rough estimate of it, but they're going to face some real risk, and it's complicated.
It certainly is. I'm going to leave you with this final question. You, sir, are not only a physician and an epidemiologist and a scientist, but you are also an author. You have written a number of books. So as a storyteller, what's the story that we might need to kind of explain to our friends, to our families, to our children about what's going on? I know we're sort of in it, but as a storyteller, how might you, I know that most stories have a beginning, middle, and end, and we don't see the end yet, but as a storyteller, how would you approach this from a story perspective as a novelist?
Yeah, I would have everybody reread Albert Camus' The Plague, first of all, because I think that it, even though it's an allegorical novel, so we know that epidemics are natural and predictable. We always get surprised, and we never learn the lesson that they're natural and they're predictable. The only unpredictable part, by the way, is exactly when and how severe. So we started with a natural phenomenon, and these viruses that leapt from an animal to people started this whole thing. We live in a world where we're only one species among millions, probably. And when we interact with some, we have what's called infection as Homo sapiens. But to the predator, of course, it's just making its way through the day. So people are affected by this. And what I would probably, my story would be, You judge a society by the way you react to a stressful time. And it's not only in, did we recognize it? Did we respond? How did we respond? Will we learn anything to be more robust next time? But what value system did we apply as we were trying to control this? Did we apply truth, justice? Did we have empathy? These are the things that will have the be the story of our generation and of this particular block of time in 2020, when people look back 50 years, 100 years from now, and they'll be saying, oh, we have this horrible pandemic going on, but look what they did in 2020. And how did they do? We're going to do better than that, I would hope they would say. But that would be some of the storylines I would incorporate.
So is it fair to say right now, not the happiest of stories, but hopefully a happy ending somewhere down the road?
Well, I think what we should do is celebrate the people who, I would say, quoting from Camus again, Dr. Ryu said, it may seem like a ridiculous idea, but the only way to beat a plague is with decency. If you look at our medical profession, and I'm talking about nurses and pharmacists and docs, the whole support team in a hospital, from cleaning people to people, they showed up for work. They were decent people. No special reward promised. And that is what's happening. What I've been questioning, whether it's CDC or NIH or the government in general, is, how would you rate us now in terms of our global response? And do you feel that the values have been incorporated as we try to solve this together?
I think we will leave it there. Sir, thank you so much. You've been more than generous with your time. Again, I'm going to put you on the spot and ask if you'll come back again in a couple of weeks, so we know this is evolving. But incredibly grateful to all the many, many people who are with us today. And Suzanne says thank you. So thank you on behalf of Suzanne and everybody who's with us and all of our community. Incredibly grateful for the kindness that you were showing to all of us. It's a good example of how we need to also be. And to everybody who's been with us, thank you. Be safe, be well. And we will see you all very, very soon online. Thanks, everyone. Be well.
Thank you.